All right. Thank you, everyone, and thank you, Jill, for that. So today, as you see from the title of the talk, we're going to talk about the REPRIEVE trial. I'm calling it a whirlwind review because I'm going to talk not just about the primary publication, but what you will see as we go through this talk. There have been more than 32 published manuscripts from the REPRIEVE trial already, and those 31 of those were published before the primary study results were released. And so it's a wealth of information that has been derived from the REPRIEVE trial. And I can only touch on a little bit of it as I go through this talk. So just to highlight for you what I will cover, I'll give you a brief review of the REPRIEVE trial and the mechanistic substudy, going over briefly the study designs and the rationale for them. I'll highlight the REPRIEVE study publications to date, and then briefly review the recently published primary study results and the rationale for the decision to stop the study early, and discuss some of the implications. If you want to delve into more detail about any of the publications that I'll cover today, there's a very well-designed REPRIEVE website that the URL is listed here, and it provides not only a summary of each of the publications, but also a patient-friendly summary that you can give to your patients who might have questions about information from the REPRIEVE trial. So what was the rationale for doing the REPRIEVE study to begin with? This is a little bit of the background, but there were four major reasons for embarking on this large clinical trial. The first was that increased risk of atherosclerotic cardiovascular disease and deaths related to this among people with HIV compared to people without is about 1.5 to 2-fold. That increased risk is not mitigated by controlling for the traditional risk factors for cardiovascular disease that we often see in our population of people with HIV. HIV factors that might contribute to this increased risk include uncontrolled viral replication that by its pathophysiology leads to immunosuppression and corollary of immune activation that may not be fully reduced with control of viral replication. Although prevention guidelines suggest that HIV infection is a risk modifier for cardiovascular disease, in the non-HIV population, no population-specific preventive recommendations have been made directed toward people living with HIV. We also know from the general population that statins have been shown to lower LDL cholesterol and total cholesterol levels, reduce immune activation, suppress endothelial cell activation, and stabilize rupture-prone, or what we call vulnerable plaque, in the coronary arteries in individuals in the general population. So based in part on these effects, they also reduce the risk of or prevent cardiovascular disease events in that population. And so the hypothesis is that by showing similar effects in people living with HIV, we may see a likewise reduction of risk or prevention of cardiovascular disease events. So you may wonder what the acronym REPRIEVE came from. Well, it's a randomized trial to prevent vascular events in HIV. And the study design is highlighted here. It's a phase 3 international multi-center randomized double-blind placebo-controlled trial. The intervention that was evaluated included a 1-to-1 randomization of eligible individuals to receive either pitavastatin in a dose of 4 milligrams per day by mouth or placebo. The primary objective of the study was to determine the effects of pitavastatin as a primary prevention strategy to reduce what has been called throughout the trial, and I'll refer to these more in the acronym than the long verbal declaration of the abbreviation, major adverse cardiovascular events in people with HIV. And then there were numerous secondary and safety endpoints included in the trial that included evaluation of the effect of the intervention on each individual MACE event, all-cause mortality, LDL cholesterol, and labs and conditions and adverse events. There was a very important mechanistic substudy also conducted within REPRIEVE. It was optional for enrollment, but given the large sample size in REPRIEVE, it co-enrolled about 800 people with HIV who were followed for 2 years after entry. The primary hypothesis for the mechanistic substudy was that pitavastatin might also reduce progression of non-calcified coronary atherosclerotic plaque volume over the 2-year period of follow-up. This effect was directly measured by coronary artery computed tomography angiography, and this study was done at baseline and at the 2-year follow-up point. The objectives of the mechanistic substudy were to determine the effects of pitavastatin on the morphology and composition of non-calcified coronary atherosclerotic plaque, and this included obviously the progression of plaque volume over a 2-year period. There were also studies done to determine whether these effects were modulated by markers of inflammation and immune activation. So I'm going to digress for just a moment. For those of you who don't live and breathe the atherosclerotic cardiovascular disease risk assessment, just to review briefly for you how this was applied in the study. The ASCVD risk estimator or score was used as an enrollment or eligibility criterion in the REPRIEVE trial. And this is the website or URL for that risk estimator. This includes age, sex at birth, race, systolic and diastolic blood pressure, total cholesterol, and HDL and LDL cholesterol, and a history of diabetes, smoking, hypertension, or statin or aspirin use. In the estimator scoring, an optimal ASCVD risk is less than or equal to 6.2%. And it primarily estimates lifetime risk for those who are evaluated over the ages of 20 to 59 years. So you'll see there's some difference in applying this to our people living with HIV. The eligibility threshold for the study actually started out with enrolling only individuals with a ASCVD risk score of less than or equal to 7.5%. But it became obvious, given the global applicability or application of this trial, that a low to moderate CVD risk needed to be expanded to include those with a score of less than or equal to 15%. This eligibility threshold was used to identify individuals with low to moderate cardiovascular disease risk, and presumably those who would not otherwise qualify for statin use according to the prevention guidelines for ASCVD. The study began enrollment in 2015. It enrolled 7,769 participants with HIV. They were aged between 40 and 75 years, and more than 30% of those enrolled were women living with HIV. All were receiving antiretroviral therapy at entry and had to have a CD4 count above 100 to qualify. Patients were eligible if they had low to moderate CVD risk, as I've already stated, so that they would not normally be recommended to start a statin drug for cardiovascular disease prevention. The study was stopped in April of 2023 after the second interim analysis, and it was stopped for efficacy by the Data Safety and Monitoring Board. And as of this date, there have been more than 32 publications from the REPRIEVE trial, only one of which is the primary study result. And most of these previous publications used baseline or entry data to look at a whole host of characteristics about the study population. The primary results were presented at the IAS conference in Sydney, and you can review them in the publication in the New England Journal of Medicine that came out July 23rd. So I'm going to start by going back in history to the time of the enrollment of the REPRIEVE trial to review some of the numerous publications and their data. So the first publication, for those of you who are interested in evaluating women with HIV, was published in the HIV Clinical Trials Journal in 2017. And it was actually characterizing a campaign that was initiated to try and encourage older women to participate in the REPRIEVE trial. And this publication focused on 40 women who had HIV or were at risk for HIV infection and were surveyed for factors that might facilitate or impede their enrollment or engagement in cardiovascular disease research. And these data were used to develop this Follow Your Heart campaign to encourage women to enroll in the study. The top methods that were identified by which women obtained information about the study were talking to someone who was already enrolled in it, or talking to their doctors about the study. The top two reasons for their participating in the REPRIEVE trial were their desire to get better information about their own health. And then one of the quotes from the survey, the money helps. So as you might imagine, people enrolled in REPRIEVE were provided with some reimbursement for childcare, for transportation, and for some of the detailed evaluations that occurred in the REPRIEVE trial. The top reasons for not participating were that they had never been told about the study and didn't know where to get information. And as the study progressed, looking at factors that encouraged women or helped their participation and retention during the course of the study were receiving reminder calls and text messages, providing reimbursement for transportation and childcare, being given a list of future appointments, and a phone number of a staff member that they could call if they were having questions or issues. So none of these are particularly novel concepts, but made it pretty clear that there were some strategies that could help with recruitment of women into the trial. The second publication of the study was just two manuscripts that highlighted the rationale and the design for both the primary REPRIEVE study and the substudy, and I don't need to belabor this point any further as I've covered those. The next publication that emerged from the REPRIEVE trial looked at strategies that were incorporated into the conduct and implementation of the trial that were designed to successfully recruit a large number of people in multiple countries around the globe. And the key feature was a central coordinating center that coordinated all of these recruitment activities. There were multiple simultaneous strategies used for recruitment that included the ones listed on the slide here, but principal of these that seemed to make the most difference were the public relations, media, and website outreach, social media and online promotions. I'm not sure how much effect celebrity promotion had, but it was in there. And outreach, most importantly, on the local level to educational and advocacy groups in the communities where participants were being recruited, including contact with their community advisory boards, providing site outreach toolkits and promotional materials, and hosting community events. And in order to enroll almost 7,800 participants, you can imagine that a lot of these strategies were very helpful to local sites in providing information about the trial. So I'm now going to move into less of the administrative background and more of some of the ways that the data from the REPRIEVE trial were used in publishing information about this very large population enrolled in the study. And the first of these was the characterization of the immunologic profiles and antiretroviral therapy at the time of entry into REPRIEVE for the individuals who enrolled. The first bullet point here just highlights a very astonishing fact that the REPRIEVE took place at more than actually the number is 147 individual clinical sites in 12 different countries on 5 continents. So you can imagine that it was both geographically diverse and represented pretty much the global population of people living with HIV. The median CD4 cell count was 620. The CD4 to CD8 ratio median was 0.81. About a quarter of the individuals had a prior AIDS-defining condition, and the median duration of prior antiretroviral therapy was almost 10 years. So the most common ART regimens were really determined by the drugs that were available in the geographic regions that the study was conducted. But the most common were the ones you might imagine, NRTIs in combination with NNRTIs or an NRTI plus integrase inhibitor regimens. So pretty much modernized regimens for the geographic regions in which the study took place. There was a second publication that was really more of an opinion by the leaders of the REPRIEVE trial, Steve Grinspoon, Pamela Douglas, Dr. Hoffman, and Dr. Ribaudo, the statistician for the trial. And this really looked at how the REPRIEVE study results could be leveraged, as it was a landmark trial, including a very representative population of individuals with HIV. So some of the other underlying health characteristics at entry in participants enrolled in the REPRIEVE started to drill down into individual subpopulations and some of their characteristics that might be associated with cardiovascular disease risk. The first of these were cisgender women, sort of in midlife, again, going back to this older women population in REPRIEVE. And they evaluated those with more advanced reproductive age after controlling for chronological age, and characterized these individuals as having a higher association with metabolic dysregulation. And by more advanced reproductive age, this really means early perimenopausal or menopausal age, earlier than you might expect from the general population or chronological age. And this particular population with more advanced reproductive age had increased waist circumference, were more likely to live in sub-Saharan Africa or Latin America. And they, because of their metabolic dysregulation, increased waist circumference, these were some of the characteristics that may have led to a higher risk of potentially higher risk of cardiovascular disease events. They also looked at the characteristics of persons who identified across the transgender spectrum. And there were attempts in this trial to enroll this population as well. There was high acceptance among those who were recruited to the study of gathering their gender identity data. Participation by this group of individuals was about 1.7% of the overall population. 2.4% of these were born male and 0.3% among those who were born female, although there were differences across geographic regions. And again, another characteristic that those transgender individuals who are receiving gender-affirming treatment were more likely to have high waist circumference and some of the other underlying characteristics that might lead to increased risk of cardiovascular disease. So again, 2 subpopulations of REPRIEVE that will be important to pay attention to as we look at the primary results. This next group of studies that were published from baseline data in REPRIEVE attempted to evaluate other organ system dysfunction among participants in the REPRIEVE. There were a subset of 82 people with HIV who were noted to have increased cardiac triglyceride levels. 52% of this 82-person subset had increased levels, and 22% of those had markedly increased levels. This is known to be a factor associated with increased risk for heart failure, and the increase in cardiac triglyceride level is a marker for myocardial steatosis or FAT. And other risk factors that were identified in this subgroup for myocardial steatosis were age, high BMI, low CD4 count, and a history of injecting drug use. So cardiac steatosis contributing to cardiovascular disease risk, possibly associated with atherosclerosis, but more likely associated with heart failure. 44% of the REPRIEVE participants had at least one ECG abnormality, and the most common of these was a prolonged QTC interval. And the QTC prolongation was more common among men than women, and more common among Asian populations who had, and among those with detectable viral loads. This suggests that there may be an association with QTC interval and other abnormalities associated with HIV. At baseline, also about 38% of the REPRIEVE participants had reduced kidney function. Risk factors that led to reduced kidney function, and this was defined as an eGFR of less than 90%, were some of the other risk factors we've already highlighted among this population. Older age, higher BMI, hypertension, and of course, as I'm sure you're all aware, tenofovir use. So the next couple of publications from the REPRIEVE data drilled down on some of the baseline characteristics that were associated with cardiovascular disease. And this particular set of publications came from the REPRIEVE mechanistic substudy. Of the 755 REPRIEVE participants who were in the mechanistic substudy, coronary artery plaque was already present in almost half of these individuals, including many of those who had ASCVD risk calculator scores of less than 2.5%. So remember, this is a population with low to moderate ASCVD risk and not candidates for statin, and already almost half of them had evidence of coronary artery plaque. 35% had coronary artery calcium scores of greater than 0, and almost a quarter of them had vulnerable plaque, meaning that plaque that was likelier to cause cardiovascular events. Immune biomarker levels were higher in those who had plaque, and these are the ones that were measured in the study, as you can see here, and higher levels of immune activation and arterial inflammation. So this I found to be a relatively remarkable characteristic of the study.
Connie?
In the REPRIEVE mechanistic I'm sorry, yes?
Oh, no, you were finished the slide, but then there were 2 questions and I figured I'd just stop for 1 second, but finish your slide. I'm so sorry.
Okay, let me finish this slide and then we'll stop for a moment for questions. The mechanistic substudy also used another calculator score to also double down on identifying factors that might be associated with increased risk. And this is referred to as the LS7 score. The LS7 score in other studies has also been associated with cardiovascular disease outcomes, and this score was also evaluated at baseline for REPRIEVE participants in the mechanistic substudy. This score includes an evaluation for smoking, diet, physical activity, BMI, blood pressure, total cholesterol, glucose, and the parameters of the score identified participants as poor, intermediate, or ideal. And the only thing I really want to highlight in this graphic are the areas in yellow here. And you can see in the areas of yellow related to physical activity, which yellow refers to poor, about 40% of individuals had poor physical activity, 28% poor diet, 20% poor blood pressure measures, and 22% in the poor category for BMI and smoking. So this was a population in the mechanistic substudy, in addition to having coronary artery plaque, had many other features that placed them at increased risk for cardiovascular disease. Okay, I'll stop there.
Yeah, it was the slide before. There was a question about the difference between serum triglyceride and cardiac triglyceride.
Uh-huh.
What is the difference? Or where's cardiac? Is it measured differently?
Yes, I'm assuming it's measured differently. I'm sorry, I'm not a cardiologist, so I didn't go into the details of how it was measured. But that my guess from the way that the substudy is done, they didn't go in and take blood from the myocardium. This is from the mechanistic substudy. They look at CT scan measured triglycerides. So I imagine there's some kind of labeling of triglyceride as it goes through the myocardium that they can measure on some kind of objective measure. But if you want to look at specifically in the study, the references for the studies are indicated here.
Thanks, Connie. And then on the next slide, Nettie was asking, do we know how this might compare to baseline levels of plaque in patients who are negative for HIV?
Well, you'd have to compare it to a similar age group with low to moderate cardiovascular disease risk. And since most of the studies that have been done have looked at people with high cardiovascular ASCVD risk and haven't done this type of mechanistic substudy to the degree that this study was done, I'm not sure we know the answer to that, Nettie, but since we don't have a non-HIV comparator group in the study, I can't answer that question.
Okay, and then now that lots of questions are coming in, I think I'm going to hold more. That'll be for the end. I was trying to just do slide.
Okay. Yeah.
Okay. But Katie Riggs did either tell us or look it up that cardiac triglyceride is based on proton MR spectroscopy.
Okay.
Thanks, Katie.
I figured it was some radiologic measure of triglyceride, right. Not somebody going in and biopsying muscle.
And I'll save these other questions for later.
Okay, so thank you for that. And then just to build on the other factors at baseline that may contribute to cardiovascular risk in this population, this goes back to the concept of integrase strand transfer inhibitors being associated with weight gain. And so taking that concept in mind, people with HIV in the REPRIEVE study who were on an integrase inhibitor-based ART regimen at entry had a higher odds ratio for obesity, had higher BMI and waist circumference, and the higher BMI and waist circumference was more notable in women and non-white participants in REPRIEVE. And there's more information from another publication later about the integrase inhibitor-based ART, drilling down into some of these features. As I alluded to from the previous slide, diet quality score was optimal or good in only about half of the participants and was suboptimal or poor in about 40% of those at baseline. Saturated fat scores were also suboptimal or poor in a large proportion of the population. And these scores differed across different regions, with highest quality scores in South Asia regions and the lowest scores in sub-Saharan African regions. And poor diet quality was also associated with higher ASCVD risk score. Looking at proteomic signatures in the mechanistic substudy and their association with coronary artery calcium, a subset of 662 patients enrolled in the study showed an association with different proteomic signatures that was independent of the ASCVD risk score. And these proteomic signatures were associated with subclinical coronary artery disease phenotypes and represent distinct immune and inflammatory proteins. After looking at ASCVD risk scores, the prevalence of any plaque and of plaque with at least one visible non-calcified portion other vulnerable features was lower in females versus males in this study, and there were distinct differences in immune and inflammatory biomarkers by sex. So I think you're starting to get the sense that based on a baseline characteristics, there were a lot of factors in this population that were associated with cardiovascular disease in the non-HIV population and may have exaggerated effects even in individuals with low or moderate cardiovascular disease risk by our usual measures. In people with HIV in this study, this representation of poor cardiovascular health as measured by the LS7 score and a lot of these other factors that I've talked about were indeed associated with coronary artery plaque, with vulnerable plaque features, and with calcification. And inflammasome activation and levels of immune activation were specifically associated with coronary plaque. There was another study recently published that also tried to analyze cardiac CT measured muscle density and area around the spine. Now you might ask, why would you do that? This was part of the mechanistic substudy, but is a measure of physical activity and as we'll get to in a moment, measures of frailty. And indeed, as you might imagine, by looking just at the physical activity scores, lower muscle density and area around the spine was associated with higher levels of inflammatory markers and markers that signaled worse or more vulnerable plaque. This lower muscle density was particularly more common in older age group within the study and among those of female sex. And then getting specifically to functional impairment, there was a second sub-study that enrolled participants from REPRIEVE. This was referred to as the PREPARE study and looked at 266 participants in the REPRIEVE and identified 37% had physical function impairment. 6% of these met criteria for frailty and 42% had pre-frail characteristics. Again, risk factors for frailty and physical function impairment in this population were older age, high BMI, physical inactivity, and Black race. And when you just looked at self-reported functional impairment, it pretty much mirrored the same thing as physically measured functional impairment in the study and similar risk factors. And functional impairment was associated with increased ASCVD risk score and cardiovascular disease risk. So the REPRIEVE cohort, I'm going to diverge now to get away from just the baseline characteristics associated with cardiovascular disease, but the REPRIEVE cohort, as you might imagine, having such a broad diversity of populations enrolled and geographic diversity, is a good picture of the environment in which people with HIV are currently living around the globe. And the cohort was used for a variety of other analyses related to HIV, not specifically related to cardiovascular disease. And then going back to, as I previously suggested, the use of integrase inhibitors as a treatment in HIV, the REPRIEVE cohort was used to analyze some of the characteristics of longitudinal integrase inhibitor use with respect to weight gain and BMI. Patients who were on an integrase inhibitor regimen had higher mean BMI at entry and at year 2. There was an increase in BMI over the 2-year period that was greater in those who switched to an integrase inhibitor regimen during the follow-up period than those who entered with one. And that change was greater in those who had been on an integrase inhibitor for less than 2 years. For once they reached the 2-year mark, however, those who were on an integrase inhibitor regimen did not see a further increase in weight gain over time. And those who entered the study on an integrase inhibitor with a higher BMI at entry gained less weight over time than those who entered with a lower BMI. There was and so this is a different concept, but also attempting to look at the underlying co-infection with CMV. As you might remember, CMV has long been associated with coronary artery disease and has thought to be an co-infection that might increase cardiovascular disease risk. And in this population, however, having previous infection with CMV as measured by IgG antibody titers was not associated with any meaningful coronary artery risk in individuals who were on ART at entry. COVID occurred during the course of the REPRIEVE trial and had an impact, as you might imagine, on the participants who were being followed in the REPRIEVE trial. So the REPRIEVE cohort was evaluated in an attempt to look both at COVID infections and at vaccination rates. And looking through July of 2021, the global probability of receiving a vaccine for SARS-CoV-2 was about 55% across the REPRIEVE cohort. This varied substantially by region. There were a number of factors associated with higher rates of vaccination, and these had to do with residents in higher income countries or regions, older age, white race, male sex, higher BMI, and higher cardiovascular disease risk. Again, going back to those populations that also might have been at higher risk for serious complications of COVID. SARS-CoV-2 infection itself occurred in 13% of about 2,500 REPRIEVE participants that were evaluated. 18% of these were diagnosed clinically, and about 80% had laboratory confirmation of SARS-CoV-2 infection. Interestingly, 60% of these were asymptomatically infected, not too different from the general population with SARS-CoV-2. Those who were asymptomatic were more likely to be from low and middle income countries, of Black or African American race, of older age, and higher ASCVD risk score. So just giving you some characteristics of COVID in an HIV population. Other COVID analyses that were done with this cohort, higher BMI in the REPRIEVE cohort was associated with a more exaggerated inflammatory immune response, and lower nadir CD4 count at entry to REPRIEVE was associated with poorly functioning antibody immune response to SARS-CoV-2 and to vaccination with SARS vaccines. And those are not terribly different than what you might imagine for the general population as well. Those with a more exaggerated immune response were those who had higher BMIs, diabetes, and rates of cardiovascular disease, and those poorly functioning antibody responses were in the immunologically suppressed groups in the general population as well. A study of mechanisms that contributed to COVID-19 disease severity in people living with HIV before they got COVID infection in the REPRIEVE trial identified some changes over time in several proteins that were closely linked to inflammatory and immune response. And these were associated with COVID-related severity of disease. Some proteins identified in the pre-pandemic state of people with HIV and REPRIEVE were levels of granzyme A, B, and H. These have been identified in the general population as associated with more severe COVID disease. And indeed, these also were associated with future risk of more severe COVID disease in the REPRIEVE cohort as well. And then the last organ system that I'll highlight data from the REPRIEVE looked at liver disease, hepatic steatosis, and NAFLD, or non-alcoholic fatty liver disease, and the association with cardiometabolic risk. In this study, a subset of REPRIEVE participants underwent non-contrast CT to detect hepatic steatosis and non-alcoholic fatty liver disease. Steatosis, as defined here, had a prevalence of 22% in the REPRIEVE population and NAFLD of 21%. And both steatosis, hepatic steatosis and NAFLD were higher in males, those of older age, non-Black race, higher BMI, and other metabolic syndrome components. And interestingly, those individuals in the REPRIEVE who had hepatic steatosis or NAFLD had higher ASCVD risk scores. There was no association with current HIV or ART related factors. So these other factors were more predominant in contributing to steatosis and NAFLD. And then lastly, one more administrative detail just published that I think is important when I go on to the primary results of the REPRIEVE trial to show you that site performance was monitored carefully during the REPRIEVE trial. There were a number of strategies that were used to both monitor and enhance site performance, and these included monitoring twice yearly, the data management, participant retention, laboratory management, and reporting back to the sites, highlighting areas of deficiency that could use improvement. There were monthly site scorecards, newsletters, calls with personal outreach by the leadership of the team, and ambassador visits to sites that resulted in a continuous cycle of review, feedback, and technical support with recommendations for process improvement during the course of the trial. So now for the last part of the talk, I'm going to go on to talk about the primary results of the REPRIEVE trial, and this recently published in the New England Journal. I've already told you about the enrolled study population, so I won't go over this, but just to highlight as it was described in the trial, the primary outcomes were major adverse cardiovascular events. And just to digress for a moment, the analyses that were used in the study were time to event analyses, and they were triggered by events. So an event-triggered analysis was used for this trial. These included a composite of cardiovascular death, myocardial infarction, hospitalization for unstable angina, stroke, transient ischemic attack, peripheral artery ischemia, and revascularization events, or death from an undetermined cause. Secondary outcomes looked also at a composite of major adverse CV events or death from any cause, and each of the individual components of the primary outcome. The team also had outcomes evaluated for death from any cause, the impact of the intervention on cholesterol levels, and targeted safety events as listed here. Again, to reiterate, the study was designed to enroll 7,700 participants. It achieved that goal, and it was assessed that if that number of participants was enrolled and followed during the course of REPRIEVE, there would be 85% power to detect a 30% reduction in the risk of major adverse cardiovascular events, with a hazard ratio of 0.7 in the pitavastatin group, on the basis of accrual of a maximum of 288 events. So a big mouthful to tell you that was the sample size and analytical calculation for arriving at that sample size. There were interim efficacy and futility analyses performed during the REPRIEVE follow-up after 50% and 75% of the primary outcome events had occurred in this event-driven analysis. At the second planned interim review, the DSMB recommended stopping the trial for efficacy after accrual of 225 events had occurred, and the p-value here was highly statistically significant at the efficacy stopping boundary at this second interim review. You won't be able to see, or you might on your screen, depending on how you've enlarged it, the table here, but I'm going to highlight in the text the characteristics of baseline demographics, and just again to reiterate some of these for you, as I've already gone over some of these in the previous portions of the presentation. The study took place, or enrollment took place, starting in March of 2015 and continued through July of 2019. There were over 10,000 participants who were screened for enrollment, enrolling in 145 sites in 12 countries. The total of 7,769 enrolled were roughly evenly distributed across the pitavastatin and placebo groups. The median age was 50 years. About 65% were non-white and over 30% were women. The median ASCVD risk score was 4.5, and the median duration of follow-up was 5.1 years. And again, as I highlighted in that slide just before I started in on the primary study results, 83% of individuals were still in follow-up at the time the study was stopped after that median duration of 5 years of follow-up. So as you can see, this is almost a 10-year study, and an 83% retention rate is quite remarkable for that long of a study. HIV specific.
I'm just giving you the 10-minute warning, and I'm sure there's going to be questions, so just letting you know. There's
only going to be three or four more slides. So HIV specific baseline characteristics are indicated here, and I've already gone over these, but the only one I really want to highlight here is 87% of individuals in this study had HIV RNAs below the limit of detection, another 10% below 400 copies, and only 2% had detectable HIV RNA at baseline. And here are the key slides from the primary result, the primary outcome treatment effects. I'm not going to go over each of these individually, but you can see from the plot here and the hazard ratios that nearly all of the individual and composite events favored pitavastatin and were statistically significantly in favor of pitavastatin, with hazard ratios that were approaching that 0.7 mark for most of the events that were measured in the study. And if you look at the time to event Kaplan-Meier analyses, you can see that the first event, the composite of the first event or death, also favored pitavastatin, and over time these curves began to diverge so that those on pitavastatin did much better than placebo over time. Again, another plot here showing individual characteristics, but I'm only going to highlight these on this slide in terms of subgroup treatment effects. The incidence of major adverse cardiovascular events was 4.8 per 1,000 person years in the pitavastatin group and 7.3 per 1,000 person years in the placebo group, with a hazard ratio of 0.65. Statistically significant effects favoring pitavastatin were observed in those with ASCVD scores between 5 and 10%, age greater than 60, male populations, Asia and South Asia superregions, former or never smokers, those with hypertension, LDL cholesterols less than 130, CD4 counts, irregardless of CD4 count, and those at higher income. And lastly, the effect on LDL and HDL cholesterol. This is kind of a curious presentation of those results, but the LDL and non-HDL cholesterol favored the pitavastatin group in all categories at each time point, with the sort of orange-yellow color being the pitavastatin group over time, and the blue color the placebo group over time. There were adverse events occurred in serious adverse events in 695 people in REPRIEVE in the pitavastatin group and 694 in the placebo group. None of these were statistically significant for any of the adverse events between pitavastatin and placebo, and many of them were either ones you know to be related to pitavastatin or adverse events known to be seen in people with HIV. So here are the key conclusions from the primary analysis. There was a lower incidence of major adverse cardiovascular events, with a 35% reduction in hazard ratio over a median of 5.1 years of follow-up. The 5-year number needed to treat was 106, and this decreased as the ASCVD risk category increased. The observed reduction in hazard ratio was actually larger than predicted based on reduction in LDL cholesterol, and the degree of reduction was similar to that seen with rosuvastatin in older persons without HIV. The events that were primarily seen were cardiac ischemia, stroke, and TIA, with type 1 MI being the most common event, with a high incidence of subclinical vulnerable plaque among those who experienced a type 1 MI, and across different regions with different global burden of disease. There were no differences based on entry or nadir CD4 count or presence of viremia, and pitavastatin was well tolerated with few treatment-limiting adverse events, leading the investigators to recommend that statins should be considered for people with HIV at low to moderate risk of atherosclerotic cardiovascular disease. And while the study results were specific to pitavastatin, other statins may have similar effects, as suggested by similar results in this study to those seen with other statins in the general population. So I'm just going to end there, Jill, and we have 5 more minutes for questions.
I'm sure there are going to be a bunch, but there were 2 from before. Lalo asked, relative to other organ dysfunction, do we know if baseline cognitive measures were collected at baseline and follow-up?
Yes, they were. They were not among the publications from REPRIEVE. So as I highlighted as the last sentence on that last conclusion slide, there are likely to be a host of other publications that will emerge from the REPRIEVE trial. So more to come.
I will get to Jeff in 1 second, who has his hand raised. There was a question about the choice. Well, the question is there a difference in cholesterol levels between atorvastatin and pitavastatin? But I think maybe the question is why the choice of pitavastatin, because it is very expensive and, you know, rolling into the real world, maybe a little bit more challenging to get in certain places.
Well, I think that goes into sort of I'm trying to think of a good word for it. The challenges of study design. You use what you have access to in a clinical trial in many cases. In this situation, pitavastatin was chosen because of it's one of the statins with the sort of least adverse event profile. It is one of the newer ones and more expensive. Atorvastatin, obviously an older one and now available generically, but in order to use atorvastatin, the study would have had to purchase that drug for 7,700 individuals, whereas having a contribution of the drug by the manufacturer helped with the decision about using that drug. It's not likely that there will be a lot of differences between pitavastatin and atorvastatin, but I think the investigators were careful in stating that the results are likely to be similar with other statins to get to that point of why use pitavastatin and not some other less expensive, more generically available statin. So
that's very helpful.
The best answer I can give you for that one.
I think it's
the only other just really quickly, the only other caveat to that is I was asking my husband about that this morning, and he said it is supposed to be better at lowering triglycerides. So that might be one clinical difference.
Yeah, I forgot to mention that. Thank you, Gigi. That's very important. But I think it also has a better side effect profile than atorvastatin. So,
Jeff, go ahead.
I'm hearing that they're considering extending the study as an observational cohort, and so I wanted to see if that's true, and just say I hope it is, because it would be hugely important for the aging field, and that's where we're going with our demographics. So if you could tell us more.
That's not something I have heard, Jeff, and the team is rapidly having every site take patients off studies. So if there's an attempt to look at an observational follow-on study to that, they would have to, by the end of this month, all of the people enrolled in REPRIEVE will be off study. So don't think there's a plan to do that.
Okay, the reason I'm asking is one of the study PIs got a survey asking about that. Would patients be willing to stay on for that purpose? So,
well, they may be willing to stay on, but they're no longer on. So
no, I know.
you would have to re-enroll them in an observational cohort. So
sure. Thank you.
I realize it's 9 o'clock, but I think Nettie asked a good question that maybe we'll just all think about a little bit. If the standard of care is going to become statins in patients living with HIV with low to moderate risk, how do we define low? And does that mean we'll really just be recommending statins for everyone and put it in the water as we always talked about doing? What are your thoughts on that, Connie?
So Nettie, I think that's the key question. Does this mean everybody should be on a statin if you have HIV infection? And I think what these 32 other publications that I tried to highlight might give you a sense for, even within the REPRIEVE cohort, there are subgroups of patients who have factors that place them at increased cardiovascular disease risk, irrespective of that ASCVD score. And I think that what that's telling us is the ASCVD score may not be granular enough for us to use to make decisions in a population with HIV, and that we may need to be looking at some of these other ways of evaluating people with HIV who, even though they have a low ASCVD score and considered to be low at moderate risk, are really not at low or moderate risk based on some of these other factors. So the way I look at this is that given some of the characteristics of the population that was enrolled in this study, I would think about using statins in people who had a lot of those other characteristics that were looked at from the baseline data, and use those as sort of my benchmark for the people I would first consider, and then maybe not using it on everybody who didn't have a lot of those other factors. I think there will be a lot more discussion about risk assessment, as Katie is commenting in the chat, on better risk assessment for people with HIV. And I think we can get there from these data. I think there's just such a wealth of information that was collected that we may get to a risk profile for people who have low to moderate ASCVD scores who are really at increased risk and are going to be the candidates for statin among people with HIV. Right now, obviously, the conclusion is you should consider it for people who fit some of the features of patients who were enrolled in this study.
Look, Lucas has a quick question, and then we really have to wrap up.
Oh, thanks. Thanks, Jill. No, I can look at the study, but on the adverse events slide, I thought it looked like the incidence of diabetes was higher in the pitavastatin group. Did they mention that?
It was, some of these things were higher, but they were not statistically significant, Lucas.
Okay. All right, thanks.
Any last words, Connie?
No, I just, we participated in REPRIEVE here at UCSD, and we enrolled 85 participants in REPRIEVE, and we're one of the major enrollers in the mechanistic substudy. And I just want to thank our own staff for all the work that they did on the REPRIEVE study. But I think the team just did a remarkable job. 7,700 participants over a 15 or a 10-year study like this. I think there's a wealth of information that we have, not just about cardiovascular disease, but about a lot of other things that our people living with HIV are dealing with in their lives right now. And I think this has just been a remarkable study. And so thank you all for your attention.
Thank you so much. Tons of praise coming through, and I'm sure we'll be hearing about REPRIEVE and future findings as the years go on. So thanks so much, Connie.
Sure.
Bye, everyone. Have a good day.
Bye, everyone.
Weekend.
Bye.
The fellows, the applicants are long gone. So,
Yeah.